So just a little bit of background. So yeah, I do practice in New York City. So we serve about 10,000 HIV positive patients. I take care of all of them myself. No, right? That would be quite an ordeal. But we're really big on doing prevention. So just briefly, you know, with HIV now, I mean, we have patients at Mount Sinai that are in their 90s with HIV. So it's definitely a chronic manageable disease, and they're doing quite well. But treating HIV is exorbitantly expensive. They estimate the average lifetime cost $1.2 million, assuming somebody gets diagnosed in their 20s. And HIV, even in those that are perfectly treated, isn't eradicated. So it hides in the reservoir, causes you to spit out these bad cytokines, which drives a lot of inflammation. So there's accelerated cardiovascular risk, accelerated incidence of cancers. So anything that we can do to avert HIV infection is really going to be beneficial. So these are my disclosures. All right, so let's just start in. So the FDA in July 2012 approved the use of tenofovir with emtricitabine, okay? Together it's called Truvada, all right? This is just the first wave for PrEP, all right? Think down the line, there's going to be these long-acting injectables, right? So think Depo-Provera for PrEP, for prevention, all right? So it's really indicated for adults who are at high risk for becoming HIV infected. And let me just give you the dosage. It's one tablet with or without food. If you're training in internal medicine or primary care, this is really where the main uptake of PrEP is going to occur. So they estimate that there's about 40,000 people on PrEP in the US now, and that number needs to reach to 1.2 million. Those are the people that are considered at risk for HIV infection. So there were 4 trials that found PrEP to be effective for preventing HIV infection when it was taken as prescribed. There were 2 trials in women that did not show a benefit. And we're going to talk about that a little bit. There are some biological differences in terms of how the drugs accumulate in cervical-vaginal versus rectal tissue. However, what drove futility in these studies was that the women did not take the medications. Now, that's an important observation because it had to do with a lot of stigma. A lot of these studies were done in African countries. And remember that there's still a lot of stigma associated with HIV. And remember that the bottle of Truvada, if somebody were to discover a bottle of Truvada and Google it, you'll see what comes up is HIV, 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 and the automatic assumption would be that they're already infected with HIV, not necessarily that they're taking it for prevention. Importantly, all of the trials found PrEP to be safe. So there's enough data now to really show that the daily dosing of tenofovir with emtricitabine, at least in these cohorts, has been safe. So the big kind of sentinel trial was the IPREX trial, all right, pre-exposure chemoprophylaxis, what they call it, chemoprophylaxis for HIV prevention in men who have sex with men. So this was a phase 3 double-blind randomized placebo-controlled trial across the world. They took adults, HIV negative, men who have sex with men, also transgendered women, and there were 2 study arms. So one, they gave them the active drug, and the other, they gave them placebo. And their primary outcomes was just incidence of HIV. Now, these were the inclusion criteria, so it had to be adults at least 18 years of age. They had to be negative, right, prior to entry. Remember, PrEP is to prevent HIV, so you don't want to start somebody that's already infected with HIV. Normal labs, and they did exclude a lot of active issues, so serious and active illnesses, active substance use, nephrotoxic agents, and also pathological bone fractures, all right? We are starting to get more real-time data, but again, this study excluded those comorbid conditions. So the study design, in addition to one arm getting active drug and the other getting placebo, they really monitored these patients quite frequently. So they monitor them monthly. And what they did is that at each visit, they talked about risk reduction counseling, condoms, they screened for sexually transmitted infections, and they also offered HIV testing. And the results showed, this is the Kaplan-Meier curve here. This is the placebo arm. This is the active arm. You see lower incidence starts to split at about 24 weeks. There was a 44% reduction in risk. I was like, 44% reduction. Would I hang my prevention hat on that? I don't know about that. And I'm going to get to that a little bit, because when you re-randomize the analysis based on efficacy, based on patients that had detectable drug levels, that's where you see that 90+% efficacy. It was very well tolerated, very few adverse events. Nausea was slightly reported more, a little bit of weight loss, but there really was no significant differences between grade 3 or grade 4 laboratory abnormalities. And there was no drug-resistant virus found in the 100 participants that were infected after enrollment. So take-home message number one is you really want to make sure before you start someone on PrEP that that patient is HIV negative. All right? And in order to do that, you're going to do the standard HIV diagnostic test, which is an antibody test, right? Now, depending on the generation, they can pick up HIV maybe as early as 17 days up to maybe 6 to 8 weeks. If you feel someone has been recently exposed, what you also want to get to rule out infection is a viral load, a PCR test. So that's the most important concept with PrEP, is that when you onboard patients, you really got to make sure that they're HIV negative. You want to rule out acute HIV infection. If you're nervous, get a viral load in addition to the antibody test. So risk compensation. Risk compensation means if you perceive an intervention to be beneficial, are you going to change your behavior? Are you going to have more bouts of condomless sex because now you know that there's this intervention that's effective? In the IPREX trial, if you looked at both arms that got either placebo or active arm, there was less risk compensation. So there was less bouts of receptive intercourse across the study. So at least in this cohort, they did not demonstrate risk compensation. All right. So when you do the reanalysis based on drug detection levels, so let's go ahead and do that. So in the placebo group, there were 64 infections. And of course, because they were receiving placebo, there was no detectable drug level. So that's an incident density of about 3.86. In the arm that got the active drug, of the 33 infections, they could not detect any drug levels, meaning the participants didn't take it. And again, in order for PrEP to work, you have to take it. And there were only in 3 infections did they detect some drug levels. So if you redo the analysis of efficacy based on those that had detectable drug levels, that's where you see 92% reduction in risk. And that's what the data shows. It's like 90+% effective, but it's not 100%, but pretty close. So here are all the PrEP efficacy trials. Partners PrEP looked at heterosexual couples, about 4,700. Tenofovir 2 study looked at heterosexual men and women. What I want you to know that out of these 5,000 patients, almost 2/3 of them were women. So these were the results, intention to treat, but again, you re-randomized looking at efficacy by those that had detectable drug levels. That's where you're getting that 90+% efficacy. The IPREX trial we spoke about, 92%. These were the 2 trials in women that did not show efficacy. When they went back and did focus groups, what they found is that the women admitted to not taking the pills. They would even show up to their study visits and kind of throw out their pills and show them the empty bottles. Again, an important observation because of the psychosocial issues that kind of drove this poor adherence. We also showed efficacy in intravenous drug use, 74% efficacy. So it works in men, it works in women, it works in men who have sex with men, transgender, and intravenous drug users. All right. So now more recent data, real world. This is the PROUD and IPERGAY studies. The PROUD study looked at 540 men who have sex with men in England. This was a real-time study. So these were high-risk individuals. One arm, they said, we're going to give you the Truvada immediately. In the other arm, they said, hey, we're going to wait a year, and then you can start on the Truvada. Both arms got the risk reduction counseling, screening for STIs, etc. And the trial had to be stopped early because they showed an 86% reduction in incidence of HIV in the arm that got immediate treatment. Now, one thing about these studies and the others is that people were saying, well, how can you with certainty say that all of this decrease in incidence was driven by just the drug Truvada? Because they were also distributed condoms, they were being treated for STIs, they were giving counseling. Well, in the IPREX trial, the rates of condom use and the rates of STIs were the same in both arms. So the only difference between the two is that one got the active arm and the other didn't. So again, it proves that above and beyond risk reduction counseling, condoms, treatment of STIs, that PrEP is still effective. So chemoprophylaxis does work, but you need to take it in order for it to be effective. Now, the IPERGATE trial was on-demand PrEP. So this is basically a trial from France and Canada, and what you do is around an exposure, you take 2 tablets, 2 to 24 hours before, then you take 1 24 hours after, and then another 48 hours after. So 4 pills around an exposure. And I'm sure because it was in France and Canada that they took their Truvada with a glass of wine. Maybe not. Now, this one also had to be interrupted early because efficacy around just this on-demand driven PrEP. What it turned out is that a lot of these patients were having a lot of sex, so on average they were taking like 4 tablets a week. So it's difficult to really tease out how effective this is, and the CDC doesn't really recommend this style of administering PrEP. And I would caution also about women. Okay, so in order for PrEP to work, you have to take it daily for a week. That's when you reach the steady state in the plasma. 2 weeks for rectal, and it's 3 weeks for cervical vaginal. So I wouldn't be confident with just this on-demand pulse dosing for prevention, especially in women. And I would probably say if a patient said, hey, I don't want to take it daily, but I know that I'm going to have an exposure, I would talk about the data. But again, it's not really recommended. Really, PrEP should be daily dosing. In both these studies, there was no evidence of drug resistance to either of the components of Truvada. There was no significant differences in the incidence of other sexually transmitted infections in either study between the groups. But again, there's no official recommendation about doing this on-demand dosing. All right. So now more data, real-time, real-world, San Francisco, Kaiser system. They just basically looked at real-time prescribing of pre-exposure prophylaxis. They looked at 32 months of observations, about 1,000 individuals that were referred for PrEP. 64% of them started. Over 2.5 years, no new HIV infections among PrEP users. Now, 30% did develop a sexually transmitted infection by 6 months, and it was over half by 12 months. And the usual suspects, chlamydia, gonorrhea, and syphilis. And here we did see some risk compensation. 56% reported no change in condom use, but 41% reported decrease in condom use. So something for us to keep an eye out on. But we have to keep our eye on the prize, right? And that's averting HIV infection, right? Because that's really what's the most damaging. That's really what can alter one's quality of life. The other sexually transmitted infections, yes, we can treat, we can eradicate. But remember, it does not prevent bacterial STIs or hepatitis C. Now, just this week, I had a patient, he's positive. He came to me because he had this bump in his liver enzymes, history of intravenous methamphetamine use. So I'm thinking, let me rule him out for acute hep C because he wasn't doing anabolics. He said he wasn't drinking. So I had him come in. But he told me, subsequent to the visit, he goes, my partner, who is HIV negative and is on PrEP, just sent me a text that he has gonorrhea, chlamydia, syphilis, and hep C. I was like, that's all? No, but it really highlights what PrEP can and can't do, right? No HIV seroconversion, and it did. And again, I think we have to wrap our minds around this prevention. Anything that anybody can do to empower themselves not to get HIV, I'm going to support. But it doesn't mean that we throw out counseling about risk reduction, about condom use, and about all of these other things that I think are important part of the implementation of PrEP.